Thank you. When I got a job at Harvard, I told my mother about it, and she didn't seem to care. She said, how does this affect your coming home for Thanksgiving? And I told her 3 weeks ago I was giving a TED Talk, and she was like, I am so proud of you. So here I am, Mom. I want to talk to you about a research program that I've been involved in ever since I left graduate school. This is a collaboration involving economists, lawyers, and doctors from Dartmouth Medical School and here at Harvard. And what unites us is the hope that through better measurement and through better data, we can improve the performance of American healthcare. And so let me share with you two insights on what we might do in terms of the work that still needs to be done. One solution is political, and the other one is organizational. Now, I am an economist, and so I am trained to inject gloom and doom to kind of motivate a lot of this work, and so I won't let you down over here. One way to kind of view the single biggest challenge facing the American economy in the years to come is to go back to 2002, and here's a quote from Peter Fisher, who was the then Undersecretary of the United States Treasury. And he said in congressional testimony, think of the US government as a gigantic insurance company with the sideline business in national defense. And this is the Bush administration. This particular insurance company has made promises to its policyholders that have a current value $20 trillion in excess of the revenues that it expects to receive. It is an accident waiting to happen. So that was Peter Fisher in 2002, and what he was trying to tell Congress was, look, if you look at the balance sheet of our government up to the year 2050, so 50 years out, we have to pay out $20 trillion more than the revenues that we expect to take in. And what this means is that we either have to raise taxes or cut benefits or do a little bit of both. Now, fast forward 10 years. These numbers were updated last year by the Congressional Budget Office, and that number of $20 trillion now stands at $40 trillion. And so the question that all of you should be asking is why? What happened in 10 years that we went from owing $20 trillion more than what we expect to take in to $40 trillion? Now, some people would say that it was the insurance expansion that Congress passed last year. So this is the thing that the Republicans like to call Obamacare, Democrats like to call Romney Care, where it turns out that this insurance expansion, flawed as it may be, actually helped reduce what we owed in terms of what we're paying out in 2050. So that's actually not responsible for this increase. What's responsible for the increase is something that no economist or physician ever expected, which is the steady avalanche of new medical technologies that are being developed at a frightening rate that we've never seen ever before. And so let me give you two examples of those technologies. The first shiny new medical technology that I want to beat up on is Avastin, bevacizumab for breast cancer. Bevacizumab for breast cancer, that little vial, costs $90,000 for a year's supply and will increase your survival by a little less than 2.5 months. Most trials find absolutely no benefit. I'm giving you the upper bound of what this has been shown to deliver in clinical trials. It works by basically starving cancerous cells a little bit more than non-cancerous cells of a protein that they need to create new blood vessels. So it starves them of something called VEGF. But it leaves you with a hole in your colon, a hole in your stomach, and a hole in your small intestine. It's costly stuff. It's very corrosive, 2.5 months of survival. The FDA, many of you know, revoked approval for Avastin yesterday for breast cancer. And so you might think our work is done. Our work is not done because Medicare, the cash-strapped public insurance program, will continue to cover this drug, even though the regulatory agency in charge of determining whether or not it's safe and effective has now ruled that this drug is not safe and effective for breast cancer. And yet, we will continue to pay for it. And so at this point, I'm not saying, gee, let's look at the $90,000 sticker. I'm saying, let's just ask, is it safe and effective? This drug is not safe and effective, and we will continue to pay for it, which is one of the many reasons that we have this massive budget deficit facing us in the years to come. Bevacizumab, though, while I've just beaten up on it, is like a mosquito bite compared to the next new thing that has been invented. I call this the Death Star of medical technologies. Nothing this big or this complicated has ever confronted modern medicine. And what I'm talking about is proton beam therapy for prostate cancer. Proton beam therapy requires us to build a cyclotron the size of a football field. And inside that particle accelerator, we accelerate protons that then emerge in the form of essentially a very thin laser, which can be used to zap cancerous cells in a man's prostate. And hope is that because it's a proton and it's so sharp and the molecules are so small, we're not going to be hurting the non-cancerous cells. There's another slide of sort of the gantry that we're actually going to put the patient on when he comes in for his proton beam therapy. Now, proton beam therapy costs $120 million. So each of those things, even before you turn the lights on, it costs $120 million. And if you're itching to get one, the Massachusetts General Hospital down the street has one. Do we have any evidence that this treatment works? We have absolutely no idea whether this treatment works. We have done no clinical trials to learn whether proton beam therapy works. But do we cover this therapy? It turns out we do. And every time we put a patient on that gantry for this unproven medical technology, the government healthcare program will cough up $1,500 to $1,800 to cover the treatment. Now, a patient who requires this treatment often needs 10 such treatments. So we as a society have essentially made the following trade-off. We have chosen to say, I would rather cover this unproven medical therapy in a man who needs this treatment than insure 3 uninsured people. That is the trade-off that we have chosen to make today in our country. And so that is sort of the single biggest reason why we have these incredible deficits. There's nothing in the Affordable Care Act that really addresses the challenge of what medical therapies will be covered and what will not. And we have done something that no other country in the world has done, which is we've jettisoned science completely from interfering with the practice of medicine. So when physicians, our insurers, are not able to say, because this drug failed clinical trial, it will, it's not something that we can actually cover. We choose to pay for everything, and the consequence of choosing to pay for everything is that $40 trillion shortfall. By the way, I realize, my students often tell me, gee, I don't really know what $40 trillion is. Well, let me just translate that into taxes. To pay $40 trillion, because we understand taxes, $40 trillion, to pay $40 trillion by 2050, the top marginal tax rate, which is now at 35%, would have to rise to 92%. We'd have to see a 160% increase in taxes. If the top marginal tax rate is 92%, we start to make Sweden look like a picnic. So that's what it kind of means for us going forward. But much more than this decision of, gee, did we cover this treatment versus that treatment, I want to draw your attention to how we're actually paying for these treatments right now. We're not raising taxes, we're not cutting benefits. So here's what's going on in my state, Massachusetts. In Massachusetts, if you look at healthcare spending over time, from 2001 to 2011, we've increased healthcare spending by about $5 billion. This is a 60% increase in healthcare spending. How did we pay for it? Well, here is the rest of the balance sheet for the state. If you look at spending on public health, mental health, education, infrastructure, human services, local aid, and public safety, those are the little piggy banks that we have been raiding to pay for healthcare spending. And what really annoys me, what saddens me as an economist is, if the thing that we care about is health, then the thing that actually improves health more than anything else is this intervention over here, education. We now know from very careful economic research that the causal effect of education on health exceeds the causal effect of more healthcare spending on health. Every additional year of schooling increases life expectancy by a little over 6 months. Very, very, very few medical technologies are able to generate that level of healthcare spending. And so while I'm all for spending on healthcare spending is sort of spending in the end game. We have to get in a lot earlier and start to invest in the things that really affect children and improve their functioning and productivity well before they sort of land up needing the Avastin or needing the proton beam therapy. So what can we do about this particular challenge? The two groups of people that I have to do battle with in my job every day are this group. So this group is the sort of, I wouldn't say all providers, I'd say about 5% of providers who benefit from the current delivery system. So there's a lot of money changing hands under the current delivery system, and I would say about 5% of hospitals and doctors are guilty for using patients' bodies as ATM machines hooked up to the United States Treasury. That has got to end. The other group is sort of the rest of us. And so the rest of us are actually responsible for some really peculiar electoral politics. I mean, if you look at who shows up, the people who actually have to pay the taxes to pay off that $40 trillion debt are outside the system completely. If you're under the age of 18, you don't get to vote. And if you look at who gets to vote, they're not the people who are going to pay for the tax increases that cover the proton beam therapy and the bevacizumab. So I have never figured out how to sort of juggle the electoral politics over here. And so my suggestion is to sort of do what we did in 1907, which is Congress has to be removed from healthcare policy. I don't think Congress can really be trusted with juggling these very long-term electoral politics. And what we need to do is create an independent agency, a lot like the Federal Reserve. This is a far more deliberative agency comprising doctors and social workers and medical ethicists and perhaps even an economist. And I think this agency will operate, you could have it operating at the national level, you could have it operating locally. This agency is the agency that will actually help us decide whether, $10,000 of revenue should be spent on healthcare, should be spent on prevention, or should be spent on education. I don't think this is a decision that Congress and our legislators can really be entrusted to do. But that is politics, and I think economists have very little to say about how to actually move the political needle forward. We're much better at coming up with small little tweaks to the current system. So is there something else that we can do right now? What I want to draw your attention to is this map of the United States, which basically shows us variation in spending for patients all over the US. And you can see some regions of the country in red are regions of the country where we spend about $13,000 per patient, and other regions are regions where we spend a lot less, about $7,000. And if you look at sort of the quality of healthcare across these regions, you see something absolutely astonishing. You see that the high-spending regions, Texas, Louisiana, Mississippi, actually rank at the very bottom of the quality of care given to their patients. That line should have been positive. It turns out it's negative. You see the same thing for hospital performance. Every dot here is an American hospital. The y-axis is survival. The x-axis is spending. And what you see is there is absolutely no association between spending and quality. So we can do a lot in terms of taking those low-performing hospitals and making them higher-performing hospitals. In fact, this difference on the y-axis is like a 12-year improvement in survival. That difference on the x-axis is like a 10-year increase in costs. So these hospitals over here are hospitals that are essentially delivering 1998 healthcare at 2012 prices. These hospitals are hospitals that deliver 2012 healthcare at 1998 prices. We have got to change that around. And so the person I work with very closely on this is my friend Atul Gawande, and I think he summarizes this enterprise best. And so let me just leave you with a quote from Atul Gawande. His view, which is mine, is that the scientific effort to improve performance in medicine can save more lives in the next decade than bench science, more lives than research on the genome, stem cell therapy, cancer vaccines, and all the laboratory work we hear about in the news. I understand and I know that this is less sexy, but this actually has the power to improve lives, to allow us to thrive, and save a lot of money, a lot faster than some of these other investments that we've been making. Thank you very much.